So in the second module of renal disorders, we'll first talk about renal trauma, which I had not covered when I was talking about abdominal trauma in the trauma module, and I told you I'll cover it in the renal module. So we'll talk about renal and ureteric trauma first, then the infections, and finally the tumors. So the first thing which we need to talk about is retroperitoneal injury. Now, retroperitoneal trauma, there are 3 zones of retroperitoneal trauma which you should know about. Now, zone 1 of retroperitoneal trauma, as you can see in the image, this is zone 1. This is where the major vessels, you have your aorta and the IVC and the pancreas are situated in this zone. This is zone 1, and zone 1 injury is associated with maximum mortality. Like it was the case in neck trauma as well. In neck also zone 1 was maximum mortality. Here also zone 1 is maximum mortality because you have your major vessels here. Zone 2 comprises of your kidney, the renal vessels and the ureter, right? So you have your kidney here, this is the kidney here, your renal vessels are going to be in zone 2, and you will also have the ureter and the colon also in front of the kidneys. Okay, so zone 2 injury will mainly involve the kidneys and the ureter and the renal vessels and the ureters. We'll talk about zone 2 injury in detail. Zone 3 injuries constitute the pelvic structures. So the pelvic structures make up zone 3 injuries, and zone 3 injuries are the most common, but majority are managed conservatively. Majority conservative management is carried out in zone 3 injuries. So these are the points, basic points, which I want you to remember in retroperitoneal trauma. Now, one more point which I want you to know, which was asked in one of the recent exams, that zone 4, this was asked 3 years back in the AIIMS exam. Now, in actual description, there is no zone 4, but there was a zone 4 described in an older classification. This is above the superior mesenteric vessels. Above the superior mesenteric vessels, if there is an injury, that will be classified as zone 4. So just for information, you can remember this. Now, what we need to talk about is zone 2 injury, that is renal injury. Now, whenever there is suspected renal injury, then we have to see whether the patient is hemodynamically stable or the patient is hemodynamically unstable. And based on this, we decide our investigation which is to be done in this patient. Now, if the patient is hemodynamically stable, then the investigation of choice here is going to be a CECT. A contrast enhanced CT scan will be the investigation of choice. But if the patient is unstable, if you remember, I told you when I was talking about FAST, what was FAST? Focus Assessment Sonogram in Trauma. And if you remember, FAST, I told you one of the drawbacks is that we can't see the retroperitoneum. And the reason for that is because the bowel gas will obscure our view of the retroperitoneum. So FAST cannot be done to see renal injury. Then what will we do? In an unstable patient, we carry out a single shot intravenous urogram. And this has been asked in the exam multiple times. A single shot intravenous urogram is carried out when you have an unstable patient where you're suspecting renal injury. Now, based on this, you have your renal injury grading, which is there. And if you remember, I told you we need to remember the splenic injury grading, and all the other organs, we'll just remember the differences. So grade 1 is same as spleen. The only difference is that there can be plus minus hematuria here. Okay. Otherwise, it is just a subcapsular hematoma like it was in spleen. Grade 2 is also same as spleen. Grade 2 is a hematoma, non-expanding hematoma, or you have a laceration less than 1 centimeter depth. Grade 3 is when the laceration is more than 1 centimeter in depth without the collecting system or urinary extravasation being involved. So the collecting system is not involved and there is no urinary extravasation as well. Grade 4 and grade 5 are different. Grade 4 in renal injury, grade 4 is when either there is urinary extravasation either there is urinary extravasation, or in these patients there is vascular injury. So those can be the two types of grade 4 injuries which can be there, and I will elaborate on this. And grade 5 is a shattered kidney, which is the same as a shattered spleen, which was also grade 5. So this is a shattered kidney. So these are the 5 grades of renal trauma which you should know about. You should also know about the pictorial representation of these trauma grades, because there was the AIIMS exam where they had shown 5 images and they had asked you to grade them from grade 1 to grade 5, and you had to arrange those images. So you should also know the pictorial representation of the injuries. Grade 1, I told you, was just a hematoma. Grade 2 was a laceration less than 1 centimeter or a bigger hematoma. Grade 3 was when the laceration was more than 1 centimeter. Grade 4 was either injury to the renal vessels or there was a urinary leak. And grade 5 is a shattered kidney. Now, grade 4 injuries, I will just discuss grade 4 and grade 5 because they are the ones which are clinically important. What I want you to know regarding the management of renal trauma. So management of renal trauma, grade 1 to grade 3 injuries are usually managed conservatively. Okay, they are managed conservatively, and these patients are usually stable. And these patients will be managed conservatively. Grade 4 injury, if it is a urine extravasation, this urine extravasation is going to give rise to a urinoma. Okay, it is going to give rise to urinoma. That means there will be collection of the urine. That is known as a urinoma. Now, this urinoma can either be a sterile urinoma, non-infected urinoma, or it can be an infected urinoma. So if it is a sterile urinoma, that means there is no fever, no pain, it is a non-infected or a sterile urinoma, then in these patients, the only treatment which is required is DJ stenting. I've already shown you what DJ stents are in the previous module, and by putting in these double J stents, we are giving a low resistance channel for the urine to come down. And urine will preferentially come down through the DJ stents, and this urinoma will gradually subside over a few days. But if it is an infected urinoma, that means there is pain also and there is fever also in these patients. Then the treatment for these patients is an ultrasound guided pigtail catheter drainage. This I have shown you at multiple places, this pigtail catheter, in the initial general surgery modules and also in the liver modules when I spoke about liver abscesses. So that is how we manage a patient with a urinoma. The other problem in grade 4 injury there can be vascular injury. Okay, there can be vascular injury which can be present as well. Now, if there is vascular injury, what will be the clinical features with which the patient is going to present? So there will be a retroperitoneal hematoma which will be there. There will be a retroperitoneal hematoma which is going to be there. And this retroperitoneal hematoma will be an increasing in size, and sometimes it can be pulsatile as well. It can be a pulsatile retroperitoneal hematoma as well. Okay, so these patients are usually unstable. And I told you, if the patient is unstable, the investigation of choice here is a single shot intravenous urogram. So if you remember the first module when I was telling you about renal agenesis, I told you that we encountered a similar case. There was a patient with trauma who had come. We were suspecting abdominal trauma. He had features of peritonitis, so we took him up for surgery. And we found that this patient had a perforation in the bowel. So we repaired that perforation, but when we opened up the abdomen, we also saw that on the left side, there was an expanding retroperitoneal hematoma. Even during the duration of our surgery, the hematoma had expanded and it was pulsatile as well. So we did a single shot intravenous urogram. What does this tell us? The dye which we inject, it goes through the renal arteries. It goes into the kidney, and it is excreted in the ureter as well. Okay, it is excreted in the ureter as well. So on the left side, what happened? We saw that the left-sided kidney, there was no uptake on the left side. The right-sided kidney normally took up the contrast and it was excreting the contrast as well. Okay, so the right kidney was normal. It was taking up the contrast, it was excreting it. But the left kidney was not visualized only, right? So not visualized can mean two things. Either the kidney is not there, or in this case, why it wasn't visualized was because there was a renal artery transection. Renal artery was injured. So because the renal artery was injured, the dye was not reaching into the kidney only. So that is why the kidney was not visualized. And we had to then explore and we had to repair the renal vessels. So we had to call in the vascular surgeons and they repaired the renal vessels in that case. So I hope you've understood this scenario, because a similar scenario was asked in the AIIMS exam 4 or 5 years back. Now, whenever you have to explore a renal injury, first we should know what type of injury is there. We should know what type of injury is present before we explore. Why? Because the retroperitoneum is a closed compartment and any hematoma there will be restricted by the tight compartment which it is. The tight fascial compartment it will be restricted. But if you blindly open the retroperitoneum, then the tamponading effect will go away and you will just have massive bleeding, and at that time you will not be able to find out what was the cause. So first figure out what was the cause and then only explore. And if there is a vascular injury, we need to repair the vascular injury, and we know that the sutures used for repairing vascular injury are Prolene sutures. A grade 5 injury is a shattered kidney, and if there is a shattered kidney, then in these patients we either have to carry out a partial nephrectomy or a total nephrectomy. But we should always see the contralateral kidney. We should see if the normal kidney, the other kidney, is normally functioning or not before we carry out this nephrectomy. Okay. So this is how we manage renal trauma. The complications of renal trauma, the patients can have hematuria. Urinoma is collection of urine. This I've already told you how to manage it. AV fistulae can form. There can be renal artery thrombosis, which can give rise to a renal infarct. Meteorism is very important. This has been asked multiple times in the exam. So meteorism is that 48 to 72 hours after retroperitoneal hematoma, which can be either because of renal injury or any other cause, 48 to 72 hours after retroperitoneal hematoma, the patient can develop colonic distension. There can be colonic distension. And this colonic distension occurs due to pressure over the splanchnic nerves. Pressure over splanchnic nerves, that can give rise to this distension, and this condition is known as meteorism. Okay. These patients following renal trauma in the long term can also develop hypertension. And the unique thing about this hypertension is that it is usually resistant to medical management. So these are the various complications which can occur following renal trauma as well. Now, ureteric injury. So ureteric injury, a lot of times this can occur when we are doing surgery. So like I told you in the previous module, that supposing you have a large retroperitoneal sarcoma or an advanced cancer, and when you're doing surgery for that, you can sometimes injure the ureter. Which is why if we know that it is a difficult surgery and there is a chance of injuring the ureter, we before doing the surgery, we get digest stents put in the ureter so that we can easily identify the ureter during surgery. Now, a lot of times gynecologists call us while doing hysterectomies, they injure the ureter. So there are 3 areas where they can injure the ureter. One is while clamping the gonadal vessels. because the ureter is closely associated with them, or when they are when they are ligating the uterine vessel, ligating uterine artery, or when they are clamping the cardinal ligaments during hysterectomy. Clamping the cardinal ligaments during hysterectomy. These are the 3 times when they can injure the ureter. Now, ureteric injury, if it is realized during surgery, that the ureter has been injured, then there are 3 things which have to be done. So if it is realized during surgery and if there is just a partial nick in the ureter, then all we need to do is we need to repair it. The second thing can be that the ureter has been completely transected, but there is no loss of segment. The ureter has been transected, but there's no loss of segment. The 2 ends are close to each other only. Here we are going to anastomose them over a DJ stent, over a double J stent. So first let me write down about these 2 and then I'll tell you about the other scenarios. So if it's a partial tear, we are going to repair it, and I've already told you we are going to use absorbable sutures here. Okay. Now if it is complete transection without loss of segment, if there's complete transection without loss of segment, then we are going to anastomose them. We spatulate the ends and anastomose over DJ stent, double J stent. The final scenario is when there is loss of segment, when some good chunk of the ureter has been transected. Okay, so now you have the 2 ends which are far apart, and because the 2 ends are far apart, I can't do primary anastomosis. Otherwise, there'll be tension and there will be a leak. So when there is loss of segment, what do? We can either use appendix to bridge the gap. We can either use appendix to bridge the gap, or we can do a Boari flap repair. Boari flap repair, I'm going to show you later. It is a bladder flap. Boari flap is a bladder flap used for reconstructing the lower end of the ureter. This is a Boari flap repair. You can see the lower end of the ureter can be reconstructed using a bladder flap. This is a Boari flap which can be used, or we can do a psoas hitch. And the last resort, if none of this works out, is to do a ureteroureterostomy. That means we join this ureter with the other ureter on the other side. Now, why do we usually avoid this? The reason why we avoid this is because if there is a problem in one of the kidneys, both the kidneys will get affected because now both the ureters are joined to each other. So that is why this is a last resort if nothing works out. But these are the various ways how a gap can be bridged just in case there has been a loss of segment. Now, these were the things which are to be done when we realize the injury during surgery. Now, if the injury is realized after surgery, if it is realized in the post-operative period, how will the patient present? First, you should know how will the patient present. Now, if the ureter has been completely tied off, that kidney will shrink. Kidney can shrink and the renal function can completely go away. There can be anuria. If both the ureters have been damaged or tied off, there can be anuria. In the postoperative period, the patient can also come with UTIs, and there can be a fistula formation as well, right? A ureterovaginal fistula can form in females. Later on, this can manifest as this way as well. So this is how the patient can present. Again, if the patient presents like this, we first have to identify the site of injury and we have to manage it accordingly, according to the ways which I have just described to you. So this is how we manage ureteric injury and renal injury. I've also told you about retroperitoneal trauma, which has also been asked in the exam. The next topic which we need to talk about is very important, and that is renal tuberculosis. So renal tuberculosis is secondary infection. It is hematogenous in nature, right? So the primary source of tuberculosis is somewhere else, and this is hematogenous spread which comes to the kidney. So the earliest lesion which we are going to get in tuberculosis of the kidney is a papillary ulcer. So this is a papillary ulcer which can form, and there can be various fates of this papillary ulcer. Now, papillary ulcer is the earliest manifestation of renal tuberculosis. Now, this papillary ulcer can track outside. It can give rise to a perinephric abscess formation. There can be perinephric abscess formation which can be there in patients. This papillary ulcer can heal with fibrosis, and multiple such ulcers can have calcium deposition around them. So they can undergo fibrosis and there can be calcium deposition around them, and this can give rise to a pseudocalculi formation. This has also been asked in the exam. There can be pseudocalculi formation. It can destroy the calluses, and there can be ghost calluses, right? There can be ghost calluses as well. And finally, we know that papillary ulcers can undergo caseous necrosis. We know in tuberculosis there can be caseous necrosis, and when there is that caseous necrosis, the entire kidney can be filled with pus. And such a pus-filled kidney is known as a putty kidney. So such a pus-filled kidney is known as a putty kidney. And if this putty kidney shows calcification, then it will be known as a cement kidney. Then we call it a cement kidney. So putty kidney or a cement kidney is when calcification occurs. And both a putty kidney and a cement kidney are non-functioning kidneys, and we ultimately have to carry out nephrectomy in these patients. So these are the various changes which can occur inside the kidney. Now, if the bacteria decides to go down the ureter, it can cause kinking of the uretropelvic junction. It can cause kinking of uretropelvic junction, and this is known as a Kerr's kink. And it can go down the ureter. It can cause beading of the ureter. Beading of the ureter can be there. Then it can even give rise to strictures inside the ureter. There can be strictures and shortening of the ureter. So there can be strictures and there can be shortening of the ureter, which can be there as well. And when it enters the bladder, it can give rise to a golf hole ureteric orifice. And this golf hole ureteric orifice is one where it remains open. So normally what happens that the ureteric orifice closes as the urine passes down and it prevents reflux. But in such patients, the ureteric orifice remains wide open, and such a ureteric orifice is known as a golf hole ureteric orifice, and there can be vesico-ureteric reflux which can occur in these patients as well. Now, in the bladder, what are the manifestations inside the bladder? So the earliest change inside the bladder, the earliest manifestation inside the bladder is paleness of the bladder mucosa. That is the earliest manifestation. Okay. Then there can be multiple ulcers which can develop. There can be ulcers inside the bladder, and when these ulcers heal with fibrosis, it can give rise to a thimble bladder. A thimble bladder is a bladder with reduced capacity because it undergoes fibrosis. So these are the manifestations inside the bladder. Then in the prostate can become boggy. And you can get a watermelon prostate on MRI as well. So you can get a watermelon prostate because the prostate is boggy. Now, there can be beading of the vas. And there can be beading of the seminal vesicles as well. The seminal vesicles can have a craggy feel, and there can be beading of the seminal vesicles, and there can be tubercular epididymoorchitis also which can develop. So these are the various manifestations of renal and genitourinary tuberculosis, and these terms are very important. They've been asked multiple times in MCQs, and this often comes as a short note in your college exams as well. Now, tuberculosis of the urinary tract, how does the patient manifest, right? So before I tell you that, just want to show you this diagram as well. I've told you most of the features when I made that diagram. One more is moth-eaten calyx or ghost calyx. This means the same thing. And the other features I've already mentioned to you as well. Now, the clinical features with which this patient is going to come. The patient can come with hematuria. Patient can come with hematuria. Patient can come with pain. Patient can come with a mass. These are the various presentations. There can also be weight loss in these patients as well. The investigation of choice is CT urography, which is nothing but a contrast enhanced CT scan specific for the kidneys and the urological system. So CT urography is the investigation of choice. Earlier, it was said that IVU, intravenous urogram, is the investigation of choice. But now CT urogram is the one which can pick up the findings the earliest, and it is considered as the investigation of choice. Let's look at some of the imaging investigations. So you can get a perinephric abscess. You can see here that there can be pus formation here around the kidney. There can be a perinephric abscess which can form, which ultimately we have to drain. Then in renal tuberculosis, you can also get a putty or a cement kidney. You can see calcification in this kidney. This is a non-functioning cement kidney which ultimately has to be removed. I told you about golf hole ureteric orifice, and golf hole ureteric orifice, this is the golf hole here. It remains wide open so that, that is how a golf hole looks like. And this is me with my uncle. We were playing, we used to play golf regularly when I was doing my fellowship there in America. And golf is probably the only sport which I play right-handed, because I started playing way back when I was in 10th class. And at that time, left-handed clubs were not available. So now it's become a habit that I play golf right-handed only. This is a Boari flap repair which can be done to correct the lower end of the ureter. This I told you previously as well. Now, the investigation of choice I told you is CT urogram, but to confirm the diagnosis, we have to collect 3 morning samples of urine, and we centrifuge them, and the sediment is subjected to ZN staining. Ziehl-Neelsen staining is done in the sediment, and that will show us acid-fast bacilli, and that is how we can confirm the diagnosis. The management of these patients, anti-tubercular drugs have to be started, and any surgical intervention, is done 4 to 6 weeks. Any intervention is done 4 to 6 weeks later. And the reason for that is that when you start anti-tubercular drugs, when healing takes place, there will be fibrosis which will occur. So further symptoms are going to manifest. So you should treat them 4 to 6 weeks later when you know the final change has happened. Now, what are the various options? Now, if the patient has a perinephric abscess, like I showed you here, so see here, if the patient has a perinephric abscess, then we have to drain this abscess. Okay. Now, if the patient has a putty or a cement kidney, here we have to carry out nephrectomy. This has been asked in the exam. These are non-functioning kidneys. Here we have to carry out a nephrectomy. If there is kinking of the ureter or there is stricture, then we put in DJ stents here. If there is shortening of the ureter, I already told you about Boari flap repair, which is used for reconstructing the lower end of the ureter. If you have a golf hole ureteric orifice, then you have to carry out re-implantation of the ureter so that reflux does not occur. And this re-implantation, we discussed previously, we will do it with the Leadbetter-Politano technique so that reflux does not happen. That I've told you in vesico-ureteric reflux. If you have a thimble bladder, which is a bladder with reduced capacity, we have to carry out augmentation cystoplasty. Augmentation cystoplasty is when we augment the capacity of the bladder, and this is done using the ileum. So we will use the ileum to augment the capacity of the bladder. So this was the management of renal tuberculosis, which is a very important topic for the exam. The next topic which we need to discuss is pyelonephritis. Now, pyelonephritis is infection of the kidney or the upper urinary tract, and this can either come via the hematogenous route, which can be blood-borne, so hematogenous route, or it can be ascending infection, or this can be ascending infection which can come secondary to urinary tract infections and secondary to vesico-ureteric reflux. Now, pyelonephritis is more common in females as compared to males, and we know that the urethra is smaller in females, so much more higher chance of urinary tract infection in females, and if that urinary tract infection goes to the upper tracts, then it can even cause pyelonephritis. Now, females are more commonly affected than males, and this is commonly seen in children. It is commonly seen in children during puberty and during pregnancy. So pyelonephritis in pregnancy can be very problematic as well, so we need to be careful about diagnosing it early. Now, the clinical features of pyelonephritis: the patient is going to come with pain in the loin. There can be fever, right? There can also be UTI symptoms which the patient can have. So pain, fever, UTI symptoms, that is burning, micturition, can also be there. Now, when we do a urine examination in these patients, you will see WBC casts. When a urine routine microscopy is done, we will see WBC casts in these patients. And when we do imaging in these patients, that is CECT, we can confirm the diagnosis on CECT. We will get to know that there is pyelonephritis. On CECT, we'll get to know the diagnosis, and on CECT, we can also differentiate this condition from pyonephrosis. Pyonephrosis is when it is a pus-filled kidney, when pus has already formed in the kidney, and the treatment for both of them is very different. So the management of this condition is antibiotics. Appropriate antibiotics have to be given. IV antibiotics have to be given in these patients, and the most common organism is E. coli. Most common organism is E. coli, which gives rise to pyelonephritis. Now, there are certain special types of pyelonephritis which you should know, because MCQs have been asked regarding this. One is emphysematous pyelonephritis, which is also due to E. coli. And I want to point out here that when I was talking about the gallbladder module, I told you about emphysematous cholecystitis as well. Emphysematous cholecystitis was because of Clostridium or gas-forming organisms. But emphysematous pyelonephritis is because of E. coli only. This is common in immunocompromised patients and diabetic patients. Patient is going to come with fever, pain, and characteristically, you're going to see gas in and around the kidney. So you can see here, you can see gas in and around the kidney. This is what clinches the diagnosis of emphysematous pyelonephritis. Now, emphysematous pyelonephritis is a serious condition where antibiotics have to be given and drainage has to be done. But if it fails, if the patient does not respond, then nephrectomy has to be done in these patients. And I know a cancer patient of mine who, after treatment, 4 years later, she was diabetic. She developed emphysematous pyelonephritis, and she ultimately had to undergo a nephrectomy as well. So, high morbidity and mortality if it is not managed properly. Another special type of pyelonephritis is xanthogranulomatous pyelonephritis. Xanthogranulomatous pyelonephritis, the main organism involved is Proteus, more common than E. coli. And this is exclusively seen in middle-aged females who suffer from diabetes mellitus as well. There can be flank pain, pyrexia, and an abdominal mass. This is how the patient is going to come with a mass, pain. And CT is characteristic. So in a CT, you will see a non-functioning kidney and you will see calculi and a low density mass as well. Now, which calculi will you see here? It is Proteus. Which calculi I told you in the first module? You can see staghorn stones. You can see staghorn or you can see struvite stones in these patients. So that is what we are going to see. And the management of xanthogranulomatous pyelonephritis. So you can see here, this is a xanthogranulomatous pyelonephritis, which you can see here. and you see this low density mass, stones can be there. And the management is subcapsular nephrectomy. Because it is a non-functioning kidney, we have to carry out a nephrectomy in these patients. Two short topics which we need to cover before we start talking about tumors. One is renal carbuncle. This is a renal cortical abscess. Renal cortical abscess. And this renal cortical abscess again is more common in diabetic patients. This is because of Staph aureus. Staph aureus is the one which is responsible for a renal carbuncle, and the management is we have to drain the abscess. We have to carry out pigtail catheter insertion, and we have to drain this abscess. Renal corticomedullary abscess is because of ascending infection. This is because of ascending infection, and this is because of E. coli, and this can even form a perinephric abscess. It can even give rise to a perinephric abscess, and we've already discussed the management is appropriate, antibiotics, and we have to drain this abscess as well with a pigtail catheter insertion. So these were the various infections of the kidney, and now we are going to talk about the renal tumors. Now, before I talk about renal tumors, there is a radiological classification of renal cysts, and this is known as the Bosniak classification. Now, if you remember, we've discussed about BIRADS, we've discussed about LIRADS, we've discussed about TIRADS, right? Similarly, for kidney, you have the Bosniak classification. And most of the tumors, it is a radiological diagnosis. We usually don't biopsy renal tumors. We make the diagnosis based on imaging. And the imaging investigation of choice is CECT. So according to the Bosniak classification, Bosniak 1 is a simple cyst. There is no risk of cancer and no further investigation required in a simple cyst. So no risk of cancer, no further workup which is required. 2 is a minimally complex cyst, same thing, zero risk of cancer and no further workup which is required. Important is 2F. So 2F is a minimally complex cyst which requires follow-up, which needs follow-up. There is a 5% risk of cancer and you need to follow up these patients with regular CT scans. Regular CT scans we'll do to see whether the lesion is increasing in size or not. Important are 3 and 4. 3 has been asked in multiple exams. 3 is an indeterminate lesion, and I will tell you later when I talk about the various tumors, I'll tell you which one usually come out as indeterminate. And indeterminate, 50% risk of cancer, and you have to carry out a partial nephrectomy here to confirm the diagnosis. So partial nephrectomy has to be done here. Okay. 4 is a clearly malignant lesion, and such clearly malignant lesions, 100% risk of cancer, and we have to do a partial or a total nephrectomy. So this is the Bosniak classification which you need to remember. So this is just a pictorial representation of the Bosniak classification. 1 is a simple benign cyst. 2 is thin septae with fine calcifications. 2F is multiple class 2 features. There's no soft tissue enhancement. This is what we need to follow up. 3 is when you have irregular or smooth thickened walls or septae which are showing enhancement. And 4 is when you have enhancement and multiple class 3 features. This is how we identify the Bosniak classification and we manage these patients accordingly. Now first we'll talk about the benign tumors of the kidney, and the first benign tumor which we'll talk about is an angiomyolipoma. Now, an angiomyolipoma is a benign tumor, and as the name suggests, this is a tumor of blood vessels. Angio means blood vessels. You have myo means muscle, and you have fat. And you have fat angiomyolipoma. And this usually arises from the perivascular epithelioid cells. So perivascular epithelioid cells are the origin, and it occurs in the 5th or the 6th decade of life. Now, these tumors can either be sporadic or they can be familial, Sporadic tumors are, of course, more common than familial tumors, but familial tumors are seen in a condition known as tuberous sclerosis, and this has been asked in multiple exams. Now, in tuberous sclerosis, in addition to angiomyolipomas, you can also get skin manifestations like adenoma sebaceum. Like adenoma sebaceum can be there. There can be ash leaf macules, which can be there. Ash leaf macules. There can be shagreen patches. There can be shagreen patches which can be there, and these patients can also have mental retardation and seizures as well. So these are the clinical features of tuberous sclerosis, and these patients can also develop multiple angiomyolipomas. Now, the clinical features of angiomyolipomas, these patients are usually asymptomatic. Usually these patients are asymptomatic, but sometimes these patients can present with pain, and they can also have massive retroperitoneal hemorrhage. Occasionally, these patients can have massive retroperitoneal hemorrhage. This tumor can start bleeding, and it can give rise to massive retroperitoneal hemorrhage, and this gives rise to Lenz triad. So this gives rise to Lenz triad, and Lenz triad is when the patient has features of pain, there is a flank mass, there is pain, and there is hypotension because of the bleeding, shock or hypotension. Mind you, there is no hematuria in Lenz triad. You should remember that. There is pain, flank mass, and hypotension. No hematuria is there. Now, the investigation of choice for angiomyolipomas is a CECT, and on CECT, classical finding is that you get this low density fat which you can see. So the appearance of this fat is the one which clinches the diagnosis of angiomyolipomas on CECT. The management of angiomyolipomas, if you have a tumor which is less than 4 centimeters, the patient is asymptomatic. Here we just monitor these patients. We keep these patients under observation. Okay. But if you have a patient where it is more than 4 centimeters or the patient is symptomatic, then in these patients we carry out a partial nephrectomy or a nephron sparing surgery. We do a partial nephrectomy or a nephron sparing surgery. They both mean the same thing. Nephron sparing surgery means partial nephrectomy. Now, if you have a patient with a bleeding angiomyolipoma, if you have a patient with a bleeding tumor, then in these patients, first we have to carry out angioembolization to stop the bleeding. We first do angioembolization to stop the bleeding, and once we've stopped the bleeding with angioembolization, then we will take up the patient for a partial nephrectomy or a nephron sparing surgery. So one thing which I want to tell you about, that when there is massive retroperitoneal hemorrhage, this is given a terminology. This is known as Wunderlich syndrome. So I just want you to note this down as well. Massive retroperitoneal hemorrhage in an angiomyolipoma is known as Wunderlich syndrome. So just make a note of that. So the next benign tumor is oncocytoma. This is the most common benign tumor of the kidney. You should remember this. It is the most common benign tumor. And these cells which it arises from are rich in mitochondria or the oncocytes. Now, oncocytoma can also be sporadic or it can be familial. Sporadic tumors are more common than familial tumors. Familial tumors can be seen in Birt-Hogg-Dube syndrome. Now, Birt-Hogg-Dube syndrome, the gene is located on chromosome 17, and these patients with Birt-Hogg-Dube syndrome, they can present with oncocytomas. They can have oncocytomas. They can have chromophobe RCCs. And they can have skin lesions like fibrofolliculomas, and trichodiscomas. So these are the various manifestations which are seen in Birt-Hogg-Dube syndrome. Now, the clinical features of patients with oncocytomas, majority of these patients are asymptomatic, but some of these patients can present with a mass as well. The investigation of choice is a CECT, and the classical finding which you get on CECT is a central stellate scar. This is very important. You can see here, you can see the central stellate scar which you can see, and that is a classical finding in an oncocytoma. Now, where else did we talk about central stellate scars? Correct. In the liver module, we spoke about central stellate scars and focal nodular hyperplasia as well. Focal nodular hyperplasia also. Now, one thing which I want you to remember is that Birt-Hogg-Dube syndrome has both oncocytomas and chromophobe RCCs. And both chromophobe RCC and oncocytoma, both chromophobe RCC and oncocytomas can both give rise to central stellate scars. So sometimes it becomes very difficult for the radiologist to differentiate between these two conditions. And when the radiologist cannot differentiate between these two conditions, which Bosniak score will he give to this? He will give a Bosniak 3. He is going to give a Bosniak 3, indeterminate. That means he cannot differentiate between the two. And when you get a Bosniak 3, the management is going to be partial nephrectomy. So we will have to carry out a partial nephrectomy in these patients if we cannot differentiate between chromophobe RCC and oncocytoma, then we have to carry out a partial nephrectomy. That will be the treatment in these patients. So these were the benign tumors of the kidney. Now let's move on to the malignant tumor, that is renal cell carcinoma. Now, renal cell carcinoma, whenever you're giving your viva, the examiner will ask you what are the other names for renal cell carcinoma. So other names are Gravit's tumor. It can also be known as a Gravit's tumor or a hypernephroma because it's mostly situated in the upper pole, hypernephroma, or another name for it is an internist tumor. And why do we call it an internist tumor? Because majority of the times it will be our internal medicine colleagues who will refer these patients to us. So these are the various names for renal cell carcinomas. And the risk factors for renal cell carcinomas are diabetes, hypertension, tobacco intake, thorotrast exposure. Remember, thorotrast was a contrast material, which I told you can even give rise to hepatocellular carcinoma. Increased protein intake. So these are the various risk factors which are there. Now there are certain syndromes also which can be associated with renal cell carcinoma. The most popular syndrome which you should know is VHL syndrome on chromosome 3, von Hippel-Lindau syndrome. This can give rise to clear cell carcinoma. It can give rise to clear cell RCC. Then you can have hereditary papillary RCC syndrome, and this can give rise to papillary RCCs. It can give rise to papillary RCCs. And you can also have Birt-Hogg-Dube syndrome, which I told you. Birt-Hogg-Dube syndrome can be associated with chromophobe type of RCCs, can be associated with chromophobe renal cell cancers. So these are the syndromes which are there. One thing which I want you to remember, that the RCCs which occur in syndromes, tend to occur early in life, and they tend to be bilateral as well. They can be bilateral RCCs as well. Now, there are various types, pathological types of renal cell cancers, and a lot of questions are asked regarding these types. The first one and the most common type is clear cell carcinoma. So clear cell is the most common type, and the question which has been asked, it arises from the proximal convoluted tubules. I just told you it is associated with von Hippel-Lindau syndrome, and the genetics of these renal cell cancers, you should know if you're preparing for the INI-CET or the super specialty exams. Only in those exams the genetics has been asked. This is given in Robbins as well. There is deletion of 3p and 6p in clear cell carcinoma. Papillary renal cell carcinoma is associated with papillary RCC syndrome. c-Met mutation, again the mutation I told you, c-Met mutations can be there. And a classical finding is psammoma bodies. Remember, we discussed about psammoma bodies in papillary thyroid cancers, in serous cystadenocarcinoma of the ovaries, in papillary RCC as well, right? So you can get psammoma bodies here. And again, there is slight controversy whether it arises more commonly from the proximal convoluted tubules or the distal convoluted tubules. But a better answer to mark will be PCT more than DCT. One very important question which has been asked multiple times, that this is the tumor which is associated with long-term dialysis, and it is the micropapillary variant which is associated with long-term dialysis therapy. This question has also been asked in the previously held AIIMS exam. Now, papillary RCC, you can see the glomeruli here. This is papillary RCC, and you can see a very small psammoma body here, right? Psammoma bodies, are foci of dystrophic calcification. So you can get psammoma bodies in these patients as well. The next type of renal cell cancer is a chromophobe RCC. Chromophobe RCC, you should remember, has the best prognosis amongst all renal cell cancers. So this has the best prognosis. It is cytokeratin positive, and there is the genetics is there is deletion of multiple chromosomes, that is 1, 2, 6, 10, and 13. So this can predispose to chromophobe RCC. I've already told you it can be associated with Birt-Hogg-Dube syndrome on chromosome 17. Another very important thing is that the slide of chromophobe RCC has been asked in the exam, and you get peculiar features like plant-like cells and raisin-like nucleus. So plant-like cells and raisin-like nucleus, and the cut section is a tan brown cut section. So gross appearance will be tan brown in color, will be the cut section, and you will see these plant-like cells and raisin-like nucleus. Of course, you need a very high power field to see the nucleus, but you see these plant-like cells here in chromophobe RCCs, which clinches the diagnosis of this condition. The final type of RCC is collecting duct or Bellini type of cancer. So this is collecting duct or Bellini type of cancer. As the name suggests, it arises from the collecting ducts. So as the name suggests, this arises from the collecting ducts, has the worst prognosis amongst all renal cell cancers. Has the worst prognosis amongst all renal cell cancers, and the genetics of collecting duct, there is deletion of 1q and there is monosomy of multiple chromosomes. Monosomy of multiple chromosomes is there. So that is the genetic abnormality which is seen in collecting duct or Bellini type of cancer. Now, what are the clinical features of renal cell carcinoma? So the classical triad of presentation is hematuria, pain, and mass. That is a classical triad, but the classical triad is only seen in 15% patients. This has also been asked. The most common presentation of renal cell cancers is hematuria. The most common presentation is hematuria. This is how patients present to us. The other presentations of renal cell carcinoma, I told you that RCCs can spread along the renal vein. They can spread along renal vein, and on the left side, this can give rise to secondary varicocele. This I told you in the surgical anatomy portion, and I've also covered in the testicular module portion. These patients can also come with cannonball metastasis to the lungs. There can be cannonball mets to the lungs, and lungs are the most common site. There can be cannonball metastasis to the lungs, and lungs are the most common site of distant metastasis in renal cell cancers. These patients can also have atypical presentations. and they can present with paraneoplastic syndromes. So paraneoplastic syndromes, you've read in pathology also, are those syndromes which cannot be explained by the direct spread or by the metastasis of the tumor. They usually occur because of compounds secreted by the tumor, which can give rise to these syndromes. Now, you should know that the most common paraneoplastic syndrome in RCC is increased ESR, is increased erythrocyte sedimentation rate. This question has been asked in the exam. There can be hypercalcemia, which can be because of PTH related peptide. Hypertension. Polycythemia can occur because of erythropoietin release. Very important for the exam is non-metastatic hepatic dysfunction. This is very, very important for the exam. So non-metastatic hepatic dysfunction is known as Stoffer syndrome, and Stoffer syndrome occurs because of raise in IL-6. There is increase in IL-6, and these patients can have increased serum bilirubin, they can have increased ALP, and they can have increased liver enzymes. But they resolve after surgery. They will resolve after surgery. And when you do a scan, you will not see metastasis into the liver. So this is Stoffer's syndrome, which you should know. There can be Cushing syndrome because of ACTH release, and there can be galactoria as well, which can be seen. The non-endocrine paraneoplastic syndromes, there can be amyloidosis, anemia, there can be neuromyopathies, and this is known as Lambert-Eaton syndrome. This is Lambert-Eaton syndrome. There can be vasculopathy, coagulopathy, and increase in prostaglandin elevation as well. This can also come, patients can also develop pyrexia of unknown origin or fever of unknown origin. That is how patients can also present. So these are the various paraneoplastic syndromes which can be there in renal cell cancers, and sometimes you just get a short note on this as well. Now, one more thing which I want to tell you, I was telling you about the types of renal cell cancers, and one more type which I want you to know is the medullary type. Now, I'm sure Dr. Ila has covered this, but I just want you to make a note of it here as well. Medullary type is seen in patients with sickle cell anemia. It is seen in patients with sickle cell anemia, and this also has a poor prognosis. This also has a poor prognosis. So you should know medullary is with sickle cell anemia. So we've discussed the clinical features. Now, how do we make the diagnosis? So the investigation of choice is a CECT. That is the investigation of choice. And that is the investigation of choice for staging these patients as well. Mind you, it is a radiological diagnosis. It is a radiological diagnosis. We don't need a biopsy. The only indications to carry out a biopsy in renal cell cancer is when it is non-operative, or it is metastatic, and we are just providing palliative treatment. That is the only time you will do a biopsy to confirm the diagnosis. Otherwise, we will act based on our radiological findings. Also, you should know that to see renal vein involvement, now this renal vein involvement is not metastasis. It is just spreading along the renal vein. To see this renal vein involvement, a CT angio should be done. A CT angio should be done. And like I told you, this is not metastasis. It is like a tumor emboli which is going into the vein. It creeps in the vein, and you can easily remove this thrombus. I'm sorry, I said emboli, it is a thrombus. So you can easily remove this tumor thrombus, even if it is in the IVC or even if it is reaching till the right side of the heart. That is what Bailey writes. So you can see the imaging here. You can see this is the tumor. And like I told you, these tumors mostly arise from the poles. So the upper pole or the lower pole of the kidney is the one which is commonly affected. Upper pole more than the lower pole. Now, the staging of renal cell cancers, this is the 8th HSCC classification for renal cell cancers. This you need to remember for the exam because questions have been asked regarding the staging and regarding management as well. So T0 is when there is no evidence of tumor. T1 is divided into T1A and T1B. T1 is less than 7 centimeters confined to the kidney. T1A is less than 4 centimeters and T1B is 4 to 7 centimeters. T2 is more than 7 centimeters confined to the kidney. And T2A is 7 to 10, T2B is more than 10 centimeters. T3 is when the tumor extends into the major veins or the perinephric tissue, but not the gland and not beyond the Girota's fascia, right? This is further divided into T3A, B, and C. T3A is when you have the renal vein involvement. T3B is subdiaphragmatic IVC, and T3C is supradiaphragmatic IVC. That is T3. And T4 is the one which has been asked multiple times in the exam. Very important that you remember T4. T4 is when it goes beyond the Girota's fascia, or it is involving the ipsilateral adrenal gland. Then it becomes T4. You should remember this for the exam. The nodes which are involved in renal cell cancers are the para-aortic lymph nodes, and N1 is when the para-aortic lymph nodes are involved. M1 is the presence of distant metastasis, and the most common site I've told you is the lungs. Now, there is another staging system for renal cell cancers, and that is known as the Robson's staging. And Robson staging is a pathological staging for renal cell cancers. It is a pathological staging for renal cell cancers. There is a grading system as well, and this has also been asked in the exam. The grading system for renal cell cancers is known as the Fuhrman's grading system. Right? So these are the points which I want you to remember in the staging. Now moving on to the management of renal cell cancers. So you need to remember that renal cell cancer surgery is the mainstay of treatment, right? And renal cell cancers are chemo and radio resistant tumors. They are chemo and radio resistant tumors, and they mainly respond to surgery only. Now the surgery for renal cell cancers, we can either do a partial nephrectomy, or we can do a radical nephrectomy, So partial nephrectomy, what are the indications for partial nephrectomy? Partial nephrectomy is done when it is a T1 tumor. T1 tumors means up till 7 centimeters, right? And this was changed. Earlier it was only till 4 centimeters, but you should remember that till 7 centimeters we can do partial nephrectomy. This tumor, if it is restricted to the poles, it is better. And if it is a bilateral RCC, where do we see bilateral RCCs? Correct, in syndromes. So bilateral RCC, I cannot remove both the kidneys, right? So I will have to do partial nephrectomy on one side. Also, if there is a renal cell cancer in a solitary functioning kidney, these are the indications to carry out partial nephrectomy. There are certain relative indications also. One is that if there is RCC in one kidney and there is a stone in the other kidney, or there is hydronephrosis in the other kidney, then we have to think about partial nephrectomy as well, because the function of the other kidney is compromised. So that is partial nephrectomy or nephron sparing surgery. Radical nephrectomy will be done in all other situations, and radical nephrectomy involves the removal of the kidney with the Girota's fascia. We remove the para-aortic lymph nodes. The para-aortic lymph nodes are removed, and the ureter is removed till pelvic brim. Ureter till the pelvic brim is removed. Right? So I will show you a video of radical nephrectomy, but these are the structures which are removed in radical nephrectomy. In some patients, plus minus ipsilateral adrenal gland is also removed. And ipsilateral adrenal gland is removed if it's an upper pole tumor and it is a T4 tumor. If it is a T4 upper pole tumor which is going into the adrenal gland, then we can remove the adrenal gland during surgery as well. Now, even if there is metastatic disease, even if the patient has a metastatic disease, still there is a role of debulking surgery. We still need to remove the primary. So debulking surgery can be done in these patients. And in metastatic disease, other medicines like mTOR inhibitors like everolimus can be used. Sunitinib and sorafenib. Sunitinib and sorafenib, I told you, are tyrosine kinase inhibitors, and we've discussed them at multiple places in GIST, in hepatocellular cancer, and also in metastatic RCC. Sunitinib and sorafenib have a role. Interleukin 2 treatment also can be used in patients with metastatic renal cell carcinomas. There is another modality which has been included in the books, and that is cryoablation of renal tumors. So in this technique, this works on the principle of rapid freezing and gradual thawing. And we take the temperature up to minus 20 degrees, and that causes lethal damage to the cells. Now, an ice ball is formed 3 to 5 millimeters from the tip. So this much tissue is destroyed whenever within 3 to 5 millimeters of the tip, all the tissue is going to be destroyed. And this cryoablation is used in T1A tumors, that is less than 4 centimeters, in patients where surgery cannot be performed, and it can be used in advanced or metastatic cancers as a palliative procedure. So these are the two indications to use cryoablation in renal tumors. The final point which you should know, so the most important prognostic factor for renal cell cancer is the pathological staging. So that takes care of RCC. Now we also have to talk about a pediatric renal malignancy, that is Wilms tumor. So Wilms tumor is the next topic which we need to discuss. And Wilms tumor, you should know, is the most common. It is the most common pediatric renal malignancy. It is the most common pediatric renal malignancy. And it is the second most common pediatric abdominal malignancy. Okay, it is the second most common pediatric abdominal malignancy, the most common being neuroblastoma, which can also be a differential diagnosis of Wilms tumor. Now, Wilms tumor commonly occurs between 2 to 5 years of age, and this can either be sporadic or it can be familial, And the three familial syndromes which are associated with Wilms tumor are Vagar syndrome, Dennis-Drash syndrome, and Beckwith-Wiedemann syndrome. So there are three syndromes which are associated with Wilms tumor. You have the Beckwith-Wiedemann syndrome, the Vagar syndrome, and the Dennis-Drash syndrome. So you can have Beckwith-Wiedemann is on chromosome 11p15, and in Beckwith-Wiedemann you can get macroglossia, omphalocele, mental retardation, Wilms tumors can be there in these patients, and the chromosome is 11p15. Beckwith-Wiedemann, you can even get hemihypertrophy. Dennis-Drash syndrome, so this was Beckwith-Wiedemann syndrome. Then you can have Dennis-Drash syndrome. Dennis-Drash is on chromosome 11, and you get genitourinary malformations, intersex abnormalities. You can get nephropathy and Wilms tumors. And you can get Vagar syndrome. Vagar syndrome is also on chromosome 11, and W is for Wilms tumor, A is for aniridia, G is for genitourinary malformations, and R is for mental retardation. This is what is seen in Vagar syndrome. Now, like we discussed in renal cell carcinoma, familial tumors tend to be bilateral, right? They tend to be bilateral in nature as well. Now, patients with Wilms tumors. So the clinical features of patients with Wilms tumors, the patient can present with hematuria. There can be hematuria. There can be an abdominal lump. And one of the features of this abdominal lump is that it rarely crosses the midline. So these patients can also have spread along the renal vein they can be spread along the renal vein like RCC. And like RCC, lungs are the most common site. Lungs are the most common site of metastasis in patients with Wilms tumors as well. So the investigation of choice to confirm the diagnosis is CECT. And on CECT, in a patient with Wilms tumor, you are going to see peripheral calcification. We will see peripheral calcification in a patient with Wilms tumor. Whereas if it is a neuroblastoma, so a differential diagnosis is neuroblastoma. In a patient with neuroblastoma, there will be intratumoral calcification. There'll be intratumoral calcification, and like I told you that the tumor can even across the midline, whereas Wilms tumors usually don't cross the midline. Now, the management of Wilms tumors. So the management of Wilms tumors would of course depend on the stage of the disease. So staging of Wilms tumor also you should know for the exam. There is one peculiar thing in Wilms tumor staging which I want you to know as well. So stage 1 is when the tumor is limited to the kidney and the tumor was completely excised. Stage 2 was tumor extending beyond the kidney but completely excised. 3 is when there's gross or microscopic residual tumor which is remaining. So it was either an R1 or an R2 resection. Stage 4 is when hematogenous metastasis is there. And stage 5 is the one which is a unique thing. Stage 5 is bilateral Wilms tumors. So this is what I want you to know. Now the management of Wilms tumors. The surgical principles of Wilms tumors are the same as RCC, right? Same as RCC. So you can either do partial nephrectomy or you can do radical nephrectomy. And I've discussed the indications of partial nephrectomy also, that if it is bilateral Wilms, if it is Wilms in a solitary functioning kidney, if it is in the upper pole, and if it is a T1 lesion, those are the indications when we can do a partial nephrectomy. Otherwise, we have to carry out a radical nephrectomy. Now, one major difference between Wilms and renal cell cancer is that Wilms tumors are chemo and radiosensitive. They are chemo and radiosensitive. And the chemotherapy which can be used in these patients is dactinomycin, vincristine, and cyclophosphamide. And cyclophosphamide are the agents which can be used in patients with Wilms tumors. Now, there are two types of approaches in patients with Wilms tumors. You can have the National Wilms Tumor Staging Group. So NWTSG is National Wilms Tumor Staging Group. Or you can have the SIOP. SIOP is Society of International Pediatric Oncologists. So, of course, you don't need to remember these names: National Wilms Tumor Staging Group and Society of International Pediatric Oncologists. The difference in the management is that National Wilms Tumor Staging Group says that do surgery first, followed by chemo plus minus RT, radiotherapy. Whereas Society of International Pediatric Oncologists say neoadjuvant chemotherapy, shrink the tumor, then do surgery plus minus radiotherapy after the surgery. So surgery will be followed by plus minus radiotherapy. So that is the difference in approach in the two organizations which are there, or the two societies which are there. This is how differently they treat the tumors. Now, the most important prognostic factor, this has been asked in multiple exams, the most important prognostic factor is the histology of the tumor. And the histology of the tumor can have epithelial components. You can have epithelial components, and there can be blastomal components. Okay, and higher the blastomal components, higher proportion of blastomal components, worse will be the prognosis. So this you should remember: higher the blastomal component in the tumor, worse will be the prognosis. So the role of the pathologist also is very important in order to prognosticate these tumors. Okay, so this brings us to the end of this module. And in these two modules, I've told you about all the kidney disorders. Like we've been doing in all modules for final year students, what is important in this module are renal TB, you get a short note. Renal TB is a short note. Renal cell cancer and Wilms tumor. These are the three short notes which you can get from this module. Before we end this module, let's quickly solve some MCQs as well. So a radiologist has shown a CT scan of a patient with a renal mass which shows a central stellate scar. Right now, I told you central stellate scar can either be an oncocytoma or a chromophobe RCC. And this is a tumor which is 5 centimeters. So which Bosniak grading will he give? I told you if you cannot differentiate the two, you will give a Bosniak 3, which is indeterminate, and we will have to carry out a partial nephrectomy in this patient. A patient with the renal swelling shows thickened walls and septations. CT reveals it to be a Bosniak type 3 cyst. What is the most probable diagnosis? This was asked in the INI CT exam, and like I told you, if you see this hypodense content which is there, this is fat, right? And fat you will see only in one tumor, that is angiomyolipoma, and you can make the diagnosis through that. So the answer is angiomyolipoma there. A 35-year-old male comes to the emergency in a state of shock. His pulse rate is 120, BP is 90 systolic. On examination, patient has a right flank swelling, which has developed in a few hours, but no history of hematuria. Most probable diagnosis. So right flank swelling, he's 35-year-old. So aneurysm, ruptured aneurysm is unlikely. The age is not of a ruptured aneurysm, okay? Oncocytoma, no. RCC, no. Angiomyolipoma, I told you, can give rise to massive retroperitoneal hemorrhage. And that will come with flank pain, and the patient will have hematuria, will have no hematuria there. Which is false regarding RCC? It is the most common renal neoplasm. Clear cell is the most common type, arises from PCT. It is not radiosensitive. Okay, this was asked in the FMG exam. A patient is diagnosed with RCC. On investigation, she is found to have spread along the IVC above the diaphragm. So supradiaphragmatic IVC, which T stage? This will be T3C. Right, T3C is supradiaphragmatic IVC, T3B is infradiaphragmatic IVC. Patient is diagnosed with a 4 centimeter RCC in the upper pole of the kidney. No distant mets or lymph nodes. So T1A tumor, upper pole, what will we do? Partial nephrectomy only. RCCs are not chemo and radio sensitive. All of the following are indications for partial nephrectomy in RCC except bilateral RCC, yes. Localized RCC and a contralateral kidney involved with the renal calculi, yes, I told you this is a relative indication. Localized RCC of any size and a normal contralateral kidney. So this is false. Of any size, how can you do it? If it's a 10 centimeter, you can't. So only till T1 we can do it, not beyond that. And RCC in a solitary functioning kidney, this is correct. This was again asked in the INI CET exam. Very good question. A mother notices a swelling in the abdomen of a 3-year-old child while bathing. History of hematuria 2 weeks back, which resolved spontaneously. There is a right-sided ballotable mass which is seen. So I told you in such patients there are two differential diagnoses. It can be Wilms and it can be neuroblastoma. So will we do a biopsy? No, we don't biopsy these lesions. These are radiological diagnoses. CECT, yes. PET CT, if it is required, we can do a PET. Urinary VMA, neuroblastoma, VMA can be raised, vinyl mandelic acid. So yes, 2, 3 and 4 will be carried out in these patients to clinch the diagnosis. Which of the following statements is false regarding acute pyelonephritis? CECT is the investigation of choice. True. Renal scarring can be seen in untreated cases. True. Surgical management is indicated if antibiotics fail. This is also true. Commonly associated with uric acid stones? No. Infected urine, you will get Staghorn calculi. You will not get uric acid stones. Final question, 42-year-old female suffering from diabetes. So keywords, identify the keywords. That is the key. Middle-aged female, diabetes. Renal stones are there, deranged KFT. CT shows bear's paw appearance. So even if you don't know that bear's paw appearance is seen in xanthogranulomatous pyelonephritis, middle-aged female, diabetes, renal stone, you can clinch the diagnosis from there that we are talking about xanthogranulomatous pyelonephritis. So this was regarding the renal module. I've told you the important topics. Invariably, one question is asked from kidney in all possible exams. So you should definitely revise these modules before your exam. Thank you.